conceive spontaneously. 55 to 60% of the patients of recurrent pregnancy loss, they conceive spontaneously. When to get the next pregnancy? That is the second question. And majority always tell that you don't conceive for 6 months, you require a gap of 6 months to all the patients. That is not, that was suggested by WHO, but a lot of papers have come up that shorter period as they are not at increased risk. So that's why we never advise any patient for any abstinence, they should go for the pregnancy with the next month onward. There are a lot of, these are all the causes of RPL. We'll go one by one. What is to be done to these cases? Congenital anatomical causes, 3D is the gold standard for duplication abnormalities and scopy is not required. Always remember that hysteroscopy and laparoscopy are not for diagnostic purpose, they are for operative purpose. 3D is the gold standard to diagnose all congenital malformations of the uterus. Only MRI may be required in some of the difficult cases or the multiple abnormalities, then you may require MRI to the patient. One of the causes is unicornuate uterus. What I would like to tell you that it is very common, it has got a bad outcome, but if you give prophylactic vaginal tablet as well as the prophylactic encerclage, then it is the treatment of choice and you can reach up to at least 7.5 months and the survival rate is very good with these babies. But remember that cervical encerclage and vaginal progesterone are the treatment of choice to this patient. Same way uterus diadelphys, there is no role of surgery, surgery should not be done, unification is not required, vaginal progesterone, cervical encerclage are the drug of choice. Same way bicornuate uterus, Strassman operation is not required, no surgery is required. These are also the patients which require cervical encerclage and the vaginal progesterone. Now septate uterus, it is always a controversial. There are a lot of papers which are coming up for the septate uterus, whether to operate or not to operate. I'll tell you some of the papers and what are the recent ASRM recommendations. Operative hysteroscopy for septum resection is a good outcome, but no definite data to justify its widespread use. A commonest thing that suppose you have done an ultrasound and you have found a septum in an infertile patient, or suppose you have done a scopy and then all of a sudden you have found a septum, is it the right way to operate? The literature never recommends for the surgery unless there is a history of an abortion. So your accidental finding or your ultrasound finding or laparoscopic finding for a septum uterus does not require a resection. There should be a minimum a history of abortion, otherwise it does not come in the way of infertility at all. Cervical encerclage and the progesterone, these are the drug of choice, and these are the recommendations. 24 septate uterus ASRM. 3D is always the gold standard. There is insufficient evidence for infertility. So septum never causes infertility. Please remember this. It is associated with spontaneous abortion and obstetric complications. Resection of the septum may or may not be associated with an increase in live birth rate. So just your patient has got an history of abortion, you have cut the septum and you tell the patient that now nothing will happen to you and the patient may abort for the second time. So that's why this counseling is very important. Surgical resection may decrease the obstetric complications, but the high quality data is still lacking. Size and shape has no relation on the reproductive outcome. Cervical septum does not increase the cervical insufficiency. Repeat surgery for a residual septum of 1 centimeter is not recommended. Estrogen balloon IUDs are not recommended after the septum resection. Treatment for infertility can be started in 1 or 2 months after the resection, and surgery is not recommended for at least who have not attempted conception. So septum resection is not indicated for infertility. These are the recommendations of 2024. Hypoplastic uterus, prophylactic encerclage and cervical progesterone. These are the necessaries. The length of the uterine length should be at least about 6 to 8 centimeter. And if that is small, then give cyclical hormonal therapy for the hypoplastic uterus and then you can start the treatment for the infertility. A good sentence, and still it holds true today also, that in a comparative study, the relative incidence of uterine abnormalities was similar in the woman without a history of recurrent miscarriage. So whether the congenital malformations they really cause the recurrent miscarriage or not, that's still not confirmed. Acquired lesions, myoma, submucous myoma, very common. Intramural myoma, 4 to 5 centimeter is considered as a cause of abortion. Still, I am not clear whether the total amount of myoma, suppose the patient has 2 millimeter myoma and patient has 6 fibroid and a single fibroid of 4 to 5 myoma, should be removed because the total volume is small. And particularly, I have seen a lot of patients who have conceived with me and delivered with 5, 7, 8 fibroids, smaller fibroids, and they never require surgery. But still, the literature says that any fibroid which is 4 to 5 centimeters, because the implantation is not good, that's why you may require surgery for this. Myomectomy is preferred over the uterine artery embolization, or the MR guided IFU is also not required for infertile patients. Acquired causes of polyp, I have never considered polyp as a cause of recurrent pregnancy loss, or rather a cause of infertility. It should not be removed when it should be removed when there are no other causes found in RPL. But still, I tell you that all of you must have experienced that the patient conceives naturally, patient delivers in spite of having the polyps inside. So I have never considered polyp as a cause of recurrent pregnancy loss in my practice. Intrauterine adhesions, it is said that it is also a cause of recurrent pregnancy loss, but in our practice, what we see, it's more of a cause of infertility rather than the recurrent pregnancy loss. We have never found that the adhesions are the common causes of the recurrent pregnancy loss. And if you get infertility, you will always try to operate these patients. Intrauterine adhesions, particularly chronic endometritis is very common nowadays. That is one of the cause of recurrent pregnancy loss as well as one of the cause of recurrent implantation failure. And that's why always you should diagnose the chronic endometritis. And this can be diagnosed by the presence of plasma cells. In the 10 envelope and high power field, if you get the plasma cells, then you can diagnose as a chronic endometritis. That is very common. Or you may go for CD138 positive cells, then also you can diagnose. But that is very costly. So if you don't diagnose, if you don't get the plasma cells, then you go for CD138. Otherwise, it is not required. Office hysteroscopy for separating the adhesions may be done for 2 to 3 cycles. Live birth rate is 41% in 1 year. Depends on the thickness, menstrual flow, and the minimal adhesiolysis on the second look hysteroscopy. So, intrauterine adhesions, particularly when the chronic endometritis is present, then it should be operated. Incompetent cause cervical length less than 2.5 to 3 centimeters, soft cervix or elastic. This is very important because many a time it is a subjective feeling whether the cervix is soft or whether it is hard. And length of the thickness, you may be 2 or 2.5 centimeters. But if you have an elastography, then the elastography will show you the green color instead of the blue color, and that is the soft cervix, which should be always ligated. Cervical encirclement and progesterones are the drug of choice. So, in nutshell, what is important is the vaginal progesterone and cervical encirclement for all the cases of congenital malformations of the uterus. And second thing is the septum does not cause the infertility. It may be a cause of recurrent pregnancy loss, that is doubtful, but still it's not the cause. And from chronic endometrium should always be diagnosed by presence of plasma cells. Now, antiphospholipid syndrome, you know, all of you know the definition. I don't go into the detail, but one laboratory and one clinical finding has to be present, and particularly 3 abortions before the 10 weeks of a normal fetus, or 1 abortion after 10 weeks of pregnancy, or even the history of IUGR that can be responsible for it. Now, what investigations we should go for it? Beta 2 glycoprotein, antiphospholipid antibody, anti-annexin do not provide any study information, and they are not required. Why I am emphasizing this? Because people ask for a lot of investigations to the recurrent pregnancy loss. Anti-nuclear antibody and anti-thyroid antibodies are also not required in the case of RPL. So these are the investigations which should not be asked for. Lupus anticoagulant is more responsible for the adverse outcome than anticardiolipin antibody, and anticardiolipin antibody normally causes the late complications. Now, mechanism all of you know very well, but I would like to tell you that what line of treatment is required for antiphospholipid syndrome. Thrombosis, anti-cytokine effect, induction of the placental apoptosis, and what is very important is antiphospholipid antibody decreases the HCG production. That's why it's not because of the luteal phase defect or not because of the any other cause, but you should supply HCG to all the patients of antiphospholipid syndrome because the production of HCG is less and the production will be less, the incidence of abortion will be very high. And autoantibodies are also produced. So this is another indications of the corticosteroids. I'll come to this point afterward, but if you give corticosteroids in the initial phases, because there are autoantibodies which are present and this can be suppressed before even the circulation is established, before even the heparin starts acting, then you can suppress these antibodies and you can progress this recurrent pregnancy loss patients that you can get a very good pregnancy outcome. Treatment options are always aspirin and heparin. It gives almost about 70 to 80% results. Aspirin is stopped always 7 days prior to your delivery and low molecular weight heparin 12 hours prior to the delivery. This is very important because when you are planning for an elective CS, when actually the heparin is to be stopped and when actually the aspirin is to be stopped. Right time termination will be very useful in these patients. Warfarin can be used after the first trimester as the low molecular weight heparin is costly and cannot be continued for all the 9 months, and that's why in a second trimester you can go for the warfarin to this patient. It prevents autoantibodies production, particularly prednisolone production secondary to antiphospholipid antibody, and it is an immunomodulator. So what I suggest that when you start corticosteroid to this patient, once the heartbeat starts, then normally the abortion rate is less than 5%. Before that it is 50%. So to reduce once the heartbeat has started, then you start decreasing your corticosteroids 5 milligram every day. The initial dose is 10 milligram 3 times a day, and then you start decreasing 5 milligram every week. So by 12 weeks there will not be steroid. All the complications which are documented in literature, the previous papers, when it is continued for almost 7 to 8 months, then the complication rates are very high. But if you initially suppress the autoantibodies with the help of prednisolone, the results will be excellent. If you ask me, I have hundreds of patients whom I have treated of recurrent pregnancy loss, particularly when the cause is not known, and the cause is mostly the autoantibodies which are present in the body. Then in initial stages, you give the steroids. Once the pulsation starts, you can remove the steroids gradually, and the pregnancy rates will be very good. Immunoglobulin has no effect except in the heparin non-response. So always the drug of choice is heparin and aspirin, but in the other causes you may go in the resistant cases you may go for immunoglobulin. Hydroxychloroquine, it has got a secondary role. Plasma exchange, that is lead therapy, has got no role. HCQ in the early pregnancy in a patient with a history of RPL does not seem to prevent further miscarriages, because I have seen a lot of prescriptions of HCQ in a patient of RPL, and this is a very current paper that 2024 that HCQ has got no role in it. ANA testing is also not useful to predict the future pregnancy loss in RPL. I am citing the current references which are come because these are the ASRM recommendations that these are not required, and that's why even the ANA testing is not required for the patient. Now for thrombophilia, all of you know the causes of thrombophilia. What I would like to tell you that they are less common in African and Asian population. It's very less. Even so many patients we have seen of recurrent pregnancy loss, it is extremely rare to see the thrombophilia patient. And screening of factor V laden mutations and PGM does not appear to be justified in the patients at risk of IVF failure and for the OHSs or thrombotic complications. But reproductive performance is normal with the thrombophilia in some of the patients. That is the main reason why it should not be investigated. Because you never know that in which patient you should be treated and which patient should not be treated. Even if you don't treat a patient of thrombophilia, they have a normal outcome. So that's why it's always very doubtful to do. Borderline screening is not required. ACOG Practice Committee Bulletin 2011, and they say that the heparin and aspirin is the treatment of choice rather than finding out the cause. Autoimmunity and autoantibodies. Patients are most likely the markers of the general breakage of autotolerance or the epiphenomenon associated with carriage of specific HLA alleles. 90% of the endometrial lymphocytes are low cytotoxicity and contain CD56 surface marker negative for CD16. Peripheral NK cells have CD56 and CD16 with the high cytotoxicity and low cytokine production. No difference in cytotoxicity and RPL has been found by many workers. It does not increase the subsequent pregnancy loss and no difference is found in control. So what does it mean that NK cell testing is not required? These are also the prednisolone reduces the endometrial. That's why in autoantibodies or initial phase of autoimmunity, prednisolone works very well. So where we cannot diagnose or when we don't know the etiology, like presence of autoantibodies or presence of NK cells or autoimmunity, then at this stage the treatment is much better than finding out the cause, and that's why the steroids are very useful to this patient. Prognostic value of measuring the peripheral NK cells or the uterine NK cell parameters remain uncertain and cannot predict who may benefit from the immunotherapy. And that's why the NK cell measurements are not required for the patients of recurrent pregnancy loss. All these investigations, anti-maternal lymphocytic antibodies, maternal blocking antibody, HLA sharing, maternal immune suppression, no clinical utility, and these investigations are not justified. Potential interventions are very much, there are so many things which are written, but it has been found by even the latest SRA guidelines also that the anti-TNF therapy, lead therapy, these are not useful at all. It's only the aspirin and low molecular weight heparin and the glucocorticoids that are useful to the patient. Otherwise, intralipids, GCSF, these are all experimental, and even in the last bulletin of the SRA SRM also, they consider it as an experimental, not useful for the therapy. This is also paternal leukocytic immunization, lead therapy. Large randomized multicentric trials have failed to demonstrate any beneficial effect, and that's why it should not be recommended to the patient. But preconceptional prednisolone, or there is only one paper that preconceptional prednisolone or intrauterine prednisolone 20 mg per day from day 1 to first or second day to the cycle for 4 weeks prior to embryo transfer. There are 1 or 2 papers available in the literature and people are working on this. And this is how they say, recommend that the prednisolone is useful for recurrent implantation failure. That is the same way I tell you that whenever you get a patient of either recurrent implantation or recurrent pregnancy loss, then this will be preventing the autoantibodies, then will be changing your NK cell population and will be very useful for the therapy. I told you that the prednisolone prevents the formation of autoantibodies, and that's why it is very useful drug, particularly in the initial phases of the pregnancy. SRA recommendation 2018, testing of HLA, anti-HLA antibodies, cytokine polymorphism, NK cells are not recommended in a woman with RPL in the clinical practice. Specific immunological treatment is given for antiphospholipid antibody only. There is insufficient evidence to use lead, IVIG, intralipids or GCSF as a treatment for RPL. These are the clear-cut recommendations of the SRA. The gene expression profile in proliferative phase in RPL can decide which patient will go for abortion irrespective of the cause. A very latest paper, 2025, that it is the proliferative phase study will decide whether this patient will abort or this patient will not abort. So that is why the gene expression in the proliferative phase, so the People are doing now a lot of research on the proliferative phase endometrium. What is the gene expression of this proliferative endometrium that is responsible for abortion, irrespective of the cause? This patient will abort and this patient will not abort. So then the therapy will be targeting towards the follicular phase. So it is because of the upregulation of the immunological pathways, and studies only of 20 genes, they have found out that only 20 genes are responsible for changes in the proliferative phase. So if you study these 20 genes and then if you try to treat these 20 genes, then you will be successful as far as the treatment is concerned. This is a very recent study and a lot of work is going on this study. Genetic causes, all of you how to investigate from the patient. But is fetal karyotyping is required? ACOG, RCOG, RC PATH and RCOG and International Workshop Denmark 2002 do not advise karyotyping of the abortus as a routine procedure, because that will tell you only what is the cause of this particular abortion. It does not tell you about the recurrent pregnancy loss. It is for the diagnosis and subsequent outcome. Most common abnormalities are balance translocation, inversion, sex chromosome mosaicism, and structural abnormalities. Parental karyotyping does not provide a diagnosis or prognosis, nor does it direct the treatment, but the current guideline recommends it. The current guideline only because of the IVF therapy, that if the patient is having a balance translocation, then which embryo should be transferred, that will be very easy. That's why people recommend it. The role of PGS, which is very expensive as the patient has to take the IVF cycle, PGS does not perform better than the expected management. A lot of papers, and that's why don't go for recurrent pregnancy loss, you don't have to go for PGS. For recurrent implantation failure, the things are different, but for recurrent pregnancy loss, the PGS is not required for the patient. There is no difference in live birth or the usable blastulation in balanced translocation compared with the controls. So that's why even for a balanced translocation, PGS is not required. Endocrine causes: hypothyroidism, hyperprolactinemia, diabetes, PCO, luteal phase defect, age-related poor ovarian reserve. Thyroid. The very important thing is that the hypothyroidism causes increase in RPL and LPD, and serum TSH is down-regulated by HCG during the first half of gestation. That's why the TSH value has got no role in the first trimester. It may vary from very lowest to the normal also. It is not required, and no recommendation for the subclinical hypothyroidism and thyroid antibody screening is not supported. So that's why majority, when the thyroid is 4.5 to 5, then people start thyroxine to each and every patient. But for infertility, 2.5 is not required. 2.5 does not increase the fertility rate. By reducing it down, once the patient conceives, then you may switch over to the therapy and you may try to bring it down to 2.5. But from the very beginning, suppose the patient remains infertile for you, for 6 months you should not give the thyroid for 6 months to the patient. And anti-thyroid antibodies are not required for the patient. Diabetes and RPL, it is for the prevention, and particularly HbA1c should be less than 7.5. Otherwise it can cause the recurrent pregnancy loss. Prolactin, still it is doubtful. There are few studies which say that it is a cause of recurrent pregnancy loss, but the few studies also deny this association, and that's why, but if the prolactin is high, then it should be treated. PCOS and RPL, very common cause, even though it is not appreciated by majority of the people, but the PCO is one of the commonest cause of the recurrent pregnancy loss we have found. And PCO morphology among the women with RPL can be as high as 40 to 56%. All of you know the causes of it, but still at present, aspirin and low molecular weight heparin improve the pregnancy loss in precia with hyperhomocystinemia and thrombophilia. When they are present, it should be. Otherwise, chronic low-dose protocol, antagonist, ovarian drilling, luteal phase support, and metformin that help in PCOS patient for the recurrent pregnancy loss. LPD occurs in all these conditions where the quality of the follicle is poor, and that's why the luteal phase support is not required in any of these conditions, but you can improve the quality of the follicle. Good ovulation stimulation protocol can take care of most of these causes of the pregnancy loss. Progesterone has immunosuppressive, uterus relaxing and vasodilating effect, and progesterone produces progesterone-induced blocking factor which causes shift from TH1 to TH2 antibodies. And progesterone supplementation may be of benefit in RPL, especially when the etiology is unexplained. Now, this is very important statement I tell you, that here the progesterone in a patient of RPL is not given because of the luteal phase defect. It is because of its immunomodulatory action that increases the TH2 from TH1 and decreases the NK cell population. That is why it is very useful. And third thing is that if you consider the PROMISE trial which was done in 2015, that the pregnancy test was considered positive, and then the progesterone was started. So you are losing your 14 days from ovulation till the pregnancy test. And that's why in all the cases of recurrent pregnancy loss, they should conceive during your treatment. And the progesterone is to be started from the day of ovulation. Then it will have a real immunomodulatory action, and then the pregnancy loss will be very less. So that's why the progesterone supplementation should be always started from the day of ovulation rather than you are late in starting it. That improves the implantation. There are a lot of papers on it. Recent Cochrane review concluded that there is a benefit of the routine progesterone supplementation in RPL. So no question of progesterone defect. The routine progesterone supplement should be given to all the patients of RPL when they are present. Extra progesterone has no risk for the fetus, and after the age of 33, the low PIPF is found in the early pregnancy, and so the routine use of the progesterone is justified. So particularly those patients who are above the 33 years of age, then progesterone-induced blocking factor is reduced in this patient, and that's why the routine use of progesterone is simplified for these patients. Vaginal route, all of you know very well that it is only because of the countercurrent mechanism that is supplied in the upper third of the vagina that the progesterone is absorbed, it goes to the vein, and from a vein it goes to the artery, and from artery it goes to the uterus. That's why uterine levels are very high as compared to the serum level. That is the advantage in only in the upper third of the vagina, and that is why the vaginal progesterone is always the drug of choice as far as the recurrent pregnancy loss are concerned. These are the immunomodulatory effect of the progesterone, and that is very useful when it is started after the ovulation. Now, uterine artery blood flow, madam has already discussed that to get a good embryo, you require a good blood flow, and that's why uterine artery blood flow should be normal to this patient. Infections, never the cause of recurrent pregnancy loss. Don't ask for the torch. Anytime, they are never the cause of recurrent pregnancy loss, and they should not be investigated for this. Environmental causes, smoking, alcohol, coffee, you must emphasize that they increase they don't cause the RPL, but they can aggravate the pregnancy loss. Too much emphasis should not be given because the patient will leave you rather than they will leave smoking. Endometriosis, its role in RPL is still not justified, and it is not considered that it is a cause of RPL. Male factor, DFI and fish were supposed to be, but we are not closer to understand the mechanism of the male contribution to the pregnancy loss, and that's why the routine testing of DFI and FIS is not indicated. Male is not supposed to be nowadays indicated as a cause for the pregnancy loss. The pregnancy loss is always because of the female causes. Sperm factors do not influence the embryonic aneuploidy, confirming the dominance of the oocyte at the female age. So that's why the male factor is not responsible for the recurrent pregnancy loss. And last slide, one of the best slides of this RPL is the psychological causes. PC sir has already showed you one case of the tender loving care. That successful pregnancy after 3 abortions is 55 to 60%, and particularly when the tender loving care is given, then it is the best. So this is the only condition which does not require other double-blind studies. This is confirmed that the tender loving care, now it should not be investigated further. It is only the test that is the definitely the helping thing. So lifestyle management and other effective therapy that is adequately proven are the first trimester progesterone, levothyroxine for subclinical hypothyroidism, and combination of aspirin and heparin in the woman with antiphospholipid antibodies. So you can see this slide that only three things are important. One is the progesterone, second is the levothyroxine in hypothyroidism, and antiphospholipid antibody, aspirin, and the heparin is to be given. These are the only documented drugs to be given in antiphospholipid syndrome. All others have the which are required for further investigations for the miscarriages. So just my carry-home message for anatomical causes, 3D ultrasound is the gold standard. Cervical encerclage and progesterone are the drug of choice. For autoimmune causes, lupus, anticoagulant and ACA should be done. Heparin and aspirin is the drug of choice. For thrombophilia, heparin and aspirin. For hormonal causes, serum TSH, anti-DPO and anti-TG, HB1C less than 7.5, serum PRL is doubtful role, insulin resistance, stromal volume, progesterone in the luteal phase, ultrasound of the endometrium in the corpus luteum, genetic causes not known, alloimmune therapy, all are doubtful, these are not required at all. Environment factor add to the pregnancy loss, endometriosis does not cause male factor is under investigation, and TLC is highly recommended. Thank you.
Thank you, Nagoritha, for that wonderful talk. As usual, it was mesmerizing and great to listen to you, sir. So, thank you once again, sir. I think the few take-home points, if we look at it from what sir said, that we need to definitely investigate her well, look at all the various hormonal parameters, etc. Because even TSH, prolactin, etc. are parameters we need to so that we give a good pregnancy outcome. Number two, he talked about a 3D ultrasound, which he said is a gold standard. Look at uterine anomalies, etc., which is very